Good evening and welcome all of you in this six episodes of IAP NRC General Club. And today with us our chairperson sir Dr. Rawat sir, our national coordinator Dr. Indu ma'am, our national expert Dr. Joseph sir, our EB member like Dr. Kasi Bandaru, Santanu Dev sir. I welcome all of you. And today our session expert is Dr. Krishna Chug. He is yet to join. I am just waiting for him to join. And I also welcome our presenter, Dr. Sumaya. She is IAP NRC Pediatric Pulmonology Fellow from the Rainbow Hospital, Banjara Hills, Hyderabad. And I also welcome our session mentor, Dr. Naveen Saradi. Sir is a pediatric pulmonologist from Rainbow Hospital, Banjara Hills, Hyderabad. So with this brief introduction, now I am handing over the session to Dr. Our coordinator, Dr. Indu ma'am, for carry forward the session. Ma'am, please.
Thank you, Dr. Ajay Kumar. We have an interesting session today on nirsevimab for prevention of hospitalization due to RSV in infants. Apart from analyzing this as an article that we do in the Journal Club, I think it has a lot of relevance in today's time and age because we are all sitting on the helm of this vaccine or this monoclonal antibody being available in our country very shortly. I think the purpose of this journal club, which I think we have been very successfully doing because of all the lovely students who have been analyzing articles very nicely, and Dr. Joseph Matthews putting in his inputs and comments on how the analysis was done. And of course, to say that the mentors have been doing a great job. So without much ado, we should go ahead with this article, and I would request for the presenter to start the presentation.
Thank you, ma'am. So, good evening, all mentors and respected faculties. So, today, in this evening, I am going to present the article Nirsevimab for Prevention of Hospitalization Due to RSV in Infants, which is presented in the New England Journal of Medicine on December 28, 2023. I am Dr. Sumaya. I am first year IAP NRC Pediatric Pulmonology Fellow from Rainbow Children Hospital, Hyderabad. My mentor is Dr. Naveen Saradi. He is my consultant in pediatric pulmonology in the institute. So, looking into the overview of my presentation, so first I will go through a literature review, then article discussion, critical appraisal by the cast poll, final conclusion, and open discussion and expert comments. Let's dive into the topic directly. So, about RSV, to begin with RSV occur in seasonal outbreaks over globally. In India, particularly southern and western parts, it corresponds to monsoon to early winter. So it is June to October and peak will be in September to October. So in north and eastern parts, actually, winter season will correspond to the outbreak. So that will be from November to February. Coming to the morbidity and mortality of RSV, we all know it is the most common cause of LRTA in children less than 1 year of age. So globally, it will account for 2% of death in less than 28 days, that is in neonates, 7% of death in infants, that is 28 to 364 days, and 2% of death in 1 to 4 year of age. So if we consider infants among 24 to 364 days, RSV is estimated to cause more death than any other single infectious agent with exception to malaria. Particularly when coming to resource-limited settings, RSV mortality occur primarily in term infants. In India, RSV is a dominant cause of bronchiolitis, which will account for 75% of cases. So, thus the importance of RSV prevention comes, since it has a high global burden of the disease, major cause of infant hospitalization. And we all know severe illness in high-risk group, that is preterms, congenital heart disease, chronic lung disease. So studies have told that RSV-associated hospitalization in less than 30 weeks is actually 3 times than that of term infants. So coming to the long-term respiratory impact of RSV, early life RSV LRTA contribute to long-term respiratory sequelae, including recurrent infection, wheezing, asthma, and impaired lung function. So let's go into the prevention of RSV, which has done year-wise. So prevention of RSV has been a long-term goal actually. So it started with a difficult start in 1960s. Early formalin inactivated RSV vaccine was used, which was abandoned later because of VAERD, which is vaccine associated enhanced respiratory disease. Again in 1990s, RSV IVIG was introduced. So this was also discontinued, basically due to interference with live vaccine and other logistic. So in 1990s, palivizumab was introduced, which is a monoclonal antibody, which was given as monthly injection, which has shown 55% reduction in hospitalization, and it is still widely used. Again in 2000, motavizumab was introduced, but it was not licensed due to risk-benefit issues. In 2020s, two vaccines had been seen, like nirsevimab and maternal RSV vaccine, which has recently licensed. We will go into the details later. So when we talk about and discuss about all these vaccines, we have to know about the F protein on the RSV. Basically, this is the F protein on the RSV. What is F protein? It is nothing but fusion glycoprotein of the RSV, which mediates fusion of the virus into the cell membrane. In this picture, you can see that it mediates the fusion of RSV into the target cell. So when we compare palivizumab and nirsevimab, both are monoclonal antibodies. So palivizumab is basically IgG1 antibody. Nirsevimab is nothing but it is a long-acting monoclonal antibody. So it is an engineered antibody of IgG1 kappa. So the target epitope for palivizumab is site 2 and target epitope of nirsevimab is site O. So neutralization potency is moderate for palivizumab. It is high for nirsevimab. And duration of protection is 30 days for palivizumab. For nirsevimab, it is 5 months. So what they have done is that they have done a YT mutation which extended the half-life of the nirsevimab, and FC engineering was done and the half-life was increased so that it can be given as a single dose for 1 season. So basically, nirsevimab is approved in all infants less than 8-month term and preterm, and 8 month to 19 month, it is approved for use in high-risk group. So in palivizumab, it is approved to use in high-risk infants, that is preterm congenital heart disease and BPD, that is chronic lung disease. Both are intramuscular injection. One is monthly injection, another is single injection. So year of approval of palivizumab is 1998 and year of approval of nirsevimab is 2022 in European Union, 2023 in USA and 2024 in India. So what we could see from studies is that there is 55% reduction in hospitalization in high-risk infant in palivizumab, which is seen by IMPACT RSV trial. So in nirsevimab group, there is a 70 to 75% of reduction in RSV LRT and hospitalization in term and preterm infants, which we could see from MELODY and HARMONY trial. Basically, we are going to discuss HARMONY trial in our study in this session. So what all are the licensed vaccine for RSV? So Synergis is the palivizumab, which is a monoclonal antibody we have discussed already. Beyfortus is nirsevimab, another long-acting monoclonal antibody.
Sorry to interrupt. Sorry to interrupt you, Sumaya, but
Yes,
we
ma'am.
want you to go into the article rather than the theory behind these
Yes,
vaccines,
ma'am.
the
Yes, yeah.
nirsevimab, and discuss
Sure.
the article, how it has been written. That we would want you to go there. Yeah, thank you.
Sure, ma'am. So let's dive into the article directly. So today's article is nirsevimab for prevention of hospitalization due to RSV in infants. So coming to the Picot format of the study, patients are healthy infants less than 12 months of gestational age more than 29 weeks entering their first RSV season and not eligible for palivizumab. So intervention was single IM dose of nirsevimab, that is 50 mg for less than 5 kg and 100 mg for more than 5 kg. So comparator was standard care, that is no intervention. So they have set two outcome, primary outcome and a secondary outcome. For primary outcome, what they have done is that hospitalization for RSV associated LRT was the primary outcome, which is defined as admission to the hospital on basis of the treating physician decision and confirmation of the RSV by a positive test. Secondary outcome, there are three secondary outcomes. First would be very severe RSV associated LRTA, defined as hospitalization for RSV associated LRTA with an oxygen saturation less than 90% and oxygen supplementation. And secondary outcome was hospitalization of RSV associated LRTA in each country. Third outcome was hospitalization for LRTA for any cause. And time frame was actually August 8, 2022 to February 28, 2023. This was the time frame for randomization, and they had done a follow-up for 366 days post randomization. Basically, this study is a part of Harmony trial. What they have done is in this study is that they have done a event-driven analysis, and they have analyze this data on February 28, 2023 at the endpoint of the randomization, which we will come later. So RSV season in these countries, that is in France, Germany and UK, corresponds to September to February, which is included in the randomization period. So they have done setting, they have done 235 sites in the respective countries. Coming to the overall design of the study, Harmony trial is a phase 3B trial, a two-group parallel two-arm study, multi-center pragmatic trial. So what is a pragmatic trial? Pragmatic trial is a real-world setting trial. Randomization is done by interactive response technology. So that is a computer-based technology, and it is done in 1:1 ratio to the nirsevimab group and standard care group, as we have discussed earlier. They have done stratification by country-wise and age group-wise. Age group at randomization was done less than 3 months, 3 to 6 months, and more than 6 months. Level and method of blinding. It is an open label study. Neither parents, guardians, nor study investigators were masked to treatment allocation. Funded by AstraZeneca and Sanofi. Compliance with International Council for Harmonization Guidelines for Good Clinical Practice and with Principles of Declaration of Helsinki. So coming to the objective and endpoints of the study. Objectives, they have divided into primary and secondary. So primary objective is to assess efficacy of nirsevimab in preventing RSV-LRT hospitalization compared to no intervention. Secondary outcome objective was to assess the efficacy of nirsevimab in preventing very severe RSV-LRT infection compared to no intervention. Then secondary objective was to assess the efficacy of nirsevimab in preventing RSV-LRT hospitalization compared to no intervention in each country. Third is to assess efficacy of nirsevimab in preventing hospitalization for all cause LRTA compared to no intervention. So endpoint, they have taken the same objectives incidence as the endpoint. Another objective of the study is to further characterize the safety profile of the nirsevimab. So endpoint they have taken as any immediate adverse event reported in 30 minutes after immunization. Any non-serious adverse effect from day 1 to day 31. Other endpoint were adverse event of special interest, medically attended adverse events, and serious adverse events from day 1 to day 366. So coming to the inclusion criteria of the study, 0 to 12-month age who entering the first RSV season on the day of inclusion, an informed consent form has been signed and dated by the parent. Participant and parent able to attend scheduled visit to comply. All study procedures were included in the study. Exclusion criteria is actually extensive, but I will break it down. Any congenital or acquired immunodeficiency, any receipt of immunosuppressive therapy and long-term systemic corticosteroid will be the first group. Any active or confirmed LRTA, confirmed RSV, active LRTA and moderate to severe acute illness and infection will be the next group. Non-systemic hypersensitivity or a history of a life-threatening reaction will be another exclusion criteria. Any contraindication for intramuscular injections like thrombocytopenia, bleeding disorder, receipt of anticoagulants in 3 weeks preceding the inclusion was also contraindication on an exclusion criteria for our study. Then, mother of an infant participant who has received RSV vaccine during her pregnancy was excluded. Any child with residual of monoclonal antibody immunoglobulins, blood or blood-derived products were excluded. Other exclusion criteria were eligible to receive palivizumab at the time of inclusion. So, sample size calculation. So, they have done initial sample size calculation based on the incidence rate 0.1% in the control group. So according to that, now 1,620 participants in each country, which will account for 28,860 participants. This would provide the trial 90% power to detect 60% efficacy at a two-sided alpha of 1.6 is adjusted using Bonferroni correction for multiple comparison. What is Bonferroni correction? Bonferroni correction is statistical adjustment used to control type 1 error rate when performing multiple comparisons or tests. So if I can tell an example, usually we take alpha as 5. Here they have 3 comparisons. So what they have done is that they have divided this alpha or type 1 error rate with 3. So their two-sided alpha is 1.6. So usually this will make the trial more stringent and reduce the type 1 error rate, but the type 2 error will increase. Basically, it will be difficult to analysis. So what they have done is that in this study, they have done a event-driven analysis. Coming to event-driven analysis, it is typically used in clinical trial, especially in context of survival analysis, time to analysis, event analysis, cumulative event assessment, example, hospitalization, progression of disease. Useful when the primary endpoint of the trial is an event that occur before analysis. So they have already told in their protocol, they have taken a 61 event of RSV related hospitalization as a trigger for primary analysis of this study. So why these 61 events were taken? So a threshold of 61 events were deemed to sufficient, 90% power to detect, 60% efficiency in preventing RSV, severe RSV disease based on the expected rate of severe RSV LRTA. So what had happened essentially is that by February 28, 2023, 71 events have occurred, leading to termination of recruitment and conducting the analysis earlier. So they have screened 8,120 children in this study, and screen failure N is number 60. So 8,058 children were randomized into nirsevimab and no intervention group. So that nirsevimab included 4,037 as number, and no intervention group included 4,021 infants. In this nirsevimab group, everyone was immunized except for one, which was like in no intervention group, one was immunized due to error in randomization. So 16 number of infants were discontinued in both groups, which is equitable. And the study was ongoing at the time of publishing the article. So coming to methodology of this study, what have done is that they have randomized and they have given the treatment allocation. During the first, on day 1, they have given either nirsevimab or no intervention. So subsequently, during the first 6 months after randomization, parents received monthly automated reminders to enter reports into the electronic diaries. So this was done remotely. If the investigators at the trial site after reviewing the reports need any further information, these parents were again interviewed. And at the end of 366th day, parents were followed up in the telephone for the safety events that occur after 181 days. So this 181th day will be the last day on which the parents have entered data into the electronic diary. So for efficacy, they have or collected data of LRT hospitalization from day 1 to day 366. We'll come into the details later. For safety, what they have done is that they have done a 30-minute post-dosing surveillance on day 1, that is day of administration of the vaccine. Then from day 1 to day 31, collection of non-serious adverse events were taken. Then collection of serious adverse events of special interest, and medically attended adverse events were taken from day 1 to day 366. So what they have done is that infants with LRTA, the treating physician in the respective country will admit them in the respective countries. They will undergo a RSV testing as a part of routine practices in their respective countries. Parents were provided with a card to give to the treating physician to encourage RSV testing if the testing had not been performed. So coming to the statistical analysis of the study, so efficacy of nirsevimab, they have calculated by two methods. One is incident rate ratio method and one is Kaplan-Meier curve and log regression method, Cox regression method. So coming to the efficacy calculation by incidence rate ratio. So what they have done is that they have calculated incidence rate ratio adjusted for person time, since the follow-up duration can vary among participants. So this is the standard formula. Efficacy is 1 minus incidence rate in nirsevimab by incidence rate in standard care group into 100. So 95% confidence interval was calculated by exact method. So this is very important. Superiority is concluded if the lower bound of confidence interval is more than 0. That is, if the entire 95% confidence interval for efficacy lies above 0, the nirsevimab is significantly better than no intervention. So efficacy calculation by Kaplan-Meier curve. So they have done a Cox regression analysis of nirsevimab and control group and has calculated hazard ratio, and 95% confidence interval had been calculated, and putting them into the efficacy formula, that is efficacy is 1 minus hazard ratio into 100, which is a standard formula. We can calculate the efficacy also. Superiority is concluded as same, lower bound of efficacy is more than 0. So coming to the results of the study, so this is the demographic characteristics of the infants at the time of randomization. So they have already, during the randomization, they have stratified according to the age and country. So the age and country wise, the number were already comparable. According to the sex, gestational age, weight also, the number were equally distributed among the subgroups. So coming to the efficacy of the primary objective or primary endpoint, efficacy of RSV-associated LRTA. In nirsevimab group, in which the N is 4,037, 11 infants underwent RSV LRTA hospitalization. In standard care group, where the N is 4,021, 60 infants underwent RSV LRTA hospitalization, which would account for 1 event per 1,000 person month and 6 event per 1,000 person month respectively. So they have calculated efficacy by two methods. Incidence-based, the efficacy was 83.2% with a 95% confidence interval of 67.8 to 92 with a p-value of 0.001, which is very significant. Efficacy with time to event, that is Cox model, is 83.3%, which is almost similar to the previous efficacy with a significant confidence interval. So looking into the Kaplan-Meier curve of the same, we can see less incidence in nirsevimab group, and in the standard care group, there is more events occurring. Coming to the subgroup analysis, actually this is very interesting. You can see this part of the subgroup analysis. In less than 3-month age group, actually the efficacy was very well seen, that is 89.6 with a good confidence interval. When coming to more than 3-month infants at time of randomization, these two groups, more than 3 month to 6 month and more than 6 month group, actually the efficacy, the lower bound is touching 0. So we could not say the superior efficacy of nirsevimab in these two groups. But in all other groups, weighted randomization, gestational age and sex, this is actually having superior efficacy. So what had happened here? So they have given an explanation for this. Actually, this could be due to the lower incidence of hospitalization in these groups. Also, this could be due to the event-driven analysis in which the preset events have already occurred in more in less than 3 months of age group, which has led to the termination of randomization. This is one another possible explanation we could give for this subgroup analysis. Also, in this subgroup analysis, less than 3 months, they have not again subgroup this into less than 37 and more than 37 weeks, that is preterm and term, which we would be interested to see actually. So efficacy of very severe RSV associated LRTA infection, that is the secondary endpoint, was also seen. So efficacy by two method was seen, which is 75.7 and 75.4. So which is also having a confident interval that is more than 0, which is significant, and p-value is 0.004%. Coming to the efficacy of RSV LRTA in different countries, in France, it was almost about 89.6% with a p-value of 0.0001%. In Germany, it is 74.2% with a p-value of 0.006%, and UK, it is 83.4% with a p-value of 0.003%. So this is the third secondary outcome. Efficacy of all-cause LRTA. So efficacy of all-cause LRTA is 58% with a 95% confidence interval of 39 to 71, which is also significant. Maybe the RSV will be the most common cause of LRTA less than 1 year. We have already discussed about the same. So coming to the safety events, we could see that any event that adverse event were equal in or almost equal in nirsevimab and standard care group, and we could not see any major adverse events in the adverse event chart also. So coming to the strength of the study is a large sample size, that too in a real world setting. So robust outcome ascertainment was done in the study. But coming to the limitation of this study was an open label design. There is a potential of bias in this study. No placebo group was done in the study. Short initial follow-up, that is minimum 3 months is the follow-up done in this analysis. So trial is ongoing at the time of publishing. Among 158 infants hospitalized for LRTA for any cause, 16 did not undergo RSV testing also. So coming to the other nirsevimab trial which had undergone earlier, Harmony trial we have already discussed. Melody trial was a phase 3 trial which has done before this. It was a randomized double-blind placebo-controlled efficacy trial. It was conducted in healthy term and preterm infants, that is more than 35 weeks of gestational age, with a sample size of 1,490. There was a placebo group, that the comparator was the placebo group. And primary outcome was medically attended RSV LRTA infection. So they could see 74.5% reduction in RSV LRTA and 62% reduction in RSV hospitalization. Another trial which was done was Medley trial. So that was a phase 2/3 trial, randomized double-blind active controlled safety trial. So basically they have taken high-risk infants, term less than 35 week, chronic lung disease and congenital heart disease. So the sample size was 925. Palivizumab was taken as an active comparator. So safety and pharmacokinetics are compared to the palivizumab. Non-inferior safety of the nirsevimab was proved in this study, and nirsevimab also met the target serum levels in the Medley trial. So coming to the critical appraisal skills program checklist. Actually, we have 4 sections in this: randomization, methodology, result, and local applicability. There will be 3 questions each in randomization, methodology, result, and 2 questions in local applicability. Let's go to the CAST checklist. Section A. Is the basic study design valid for the randomized controlled trial? So first question is, did the study address a clearly formulated research question? So Was the study designed to assess outcomes of an intervention? Yes. Is the research question formulated in the terms of Picot format? Yes, we have already discussed that. So the answer will be yes. Second question is, was the assignment of participants to the intervention randomized? How was the randomization carried out? Randomization was carried out by the interactive responsive technology. And the method appropriate? Yes, the method was appropriate. Was randomization sufficient to eliminate systematic bias? Yes, it was. Was the allocation sequence concealed from the investigators and participants? No, they were not, because this is an open label study. Were all participants who entered the study accounted for its conclusion? So things to consider were losses to follow-up and exclusion after randomization accounted for? Yes, they were accounted for. Were participants analyzed in the study group to which they were randomized? Yes, they have done an intention to treat analysis. Was the study stopped early? If so, what was the reason? Now, the study was not stopped early, but it was they have done a event-driven analysis. So the analysis was done early after randomization. So coming to the answer for this will be yes, actually. Section B, was the study methodologically sound? Yes. So coming to this point, were the participants blind to the intervention they were given? No is the answer. Investigators were neither blind. People assessing or analyzing outcome were also not blind. So the answer will be no for all questions. So were the study groups similar at the start of randomized control trial? So the answer will be yes, actually, because the baseline characteristics of each study group was equal. And were there any differences between study group that could affect the outcome? No, there were actually not. Apart from the experimental intervention, did each study group receive same level of care? So this actually we can't tell, because in each country, treating physician will decide to admit the patient, which could vary according to the individual decision and country. So parameters for the admission were also not very clearly defined. So were the follow-up intervals same for each study group? Yes, the follow-up interval was same. So what are the results? Were the effects of intervention reported comprehensively? Was a power calculation undertaken? Yes, power was calculated. What outcome was measured? Outcome was measured in form of efficacy. So what were the results expressed? So the efficacy they have expressed as binary outcomes also. Were the results reported to each outcome in each study group at each follow-up interval? Yes, that was done. Was there any missing or incomplete data? No. Was there any differential dropout? No. Differential dropout was not there. The dropout were 16, which was equal in both groups. Were the potential sources of bias identified? Yes, they were identified. Which statistical tests were used? So for efficacy calculation, they have taken incidence-based method, and the other method used was Kaplan-Meier curve and Fox regression analysis. Were the p-values reported? Yes, the p-values were reported. So was the precision of the estimate of the intervention to treat effect reported? Yes, it was reported. They have reported confidence interval. Do the benefits of experimental intervention outweigh the harms and costs? Yes, they outweigh the harms, but about the cost, they have not done a cost-effective analysis. So the answer is yes, or otherwise it can't tell. So will the result help locally? Can the results be applied to your local population or in your context? Are the study participants similar in your care? Yes, they are. Would any differences between your population and study participant alter the outcome reported in the study? So, what we could see in this study is that for infants more than 3 months of age at randomization, the efficacy was not proved since the lower bound was less than 0. So, usually in our cohort, what we see in our patient, we could see many infants more than 3 months who are affected with RSV. So, efficacy in this group is actually questionable. Are the outcome important to your population? Yes, the outcome is important. Are there any outcome you would have wanted information on that have not been studied or reported? Subgroup analysis and efficacy in high-risk group was not reported actually. Are there any limitation of study that would affect your decision? So lesser number of primary endpoint in more than 3-month age group was a limitation that would actually affect our decision making in this age group. So would the experimental intervention provide greater value to the people in your care than any other existing intervention? So in Indian context, actually it has to be taken with accessibility of the drug, cost, accessibility of the vaccine, cost and population density. So coming to the appraisal summary, so positive points of the methodologically sound study was large sample size, appropriate randomization, comparable study population characteristic, objective endpoint and protocols were clearly specified. Outcomes were objectively measured. So negative points were no blinding, short follow-up and cost-effective analysis was not done. So coming to the just one slide about the use of nirsevimab, which is recommended by CDC in 2023. So recommendation of use of nirsevimab, ACIP recommend 1 dose of nirsevimab for all infants less than 8 months born during entering their first RSV season, and ACIP recommend 1 dose of nirsevimab for infants and children 8 to 9 months who are at increased risk of severe RSV disease and entering their second RSV season. So now I am opening the discussion for expert comments. So thoughts on implementation in Indian context, consideration for cost effectiveness and access. We could discuss all those points. Thank you.
You can stop sharing, Dr. Surmaya.
Sure, sir.
So I'm not very sure if Dr. Indu Madam is online, though I can see that she's logged in. So in that case, let us take some inputs. I think the first input goes to Professor Dr. Chugh as the expert on this session. So Dr. Chugh for comments, sir.
Thank you. Thank you so much. It was a really detailed discussion on the whole paper, whole study. And I think we looked into almost every angle of it. And we did draw some nice conclusions also. I think some points that come out are that this study did prove, taken totally, yes, that nirsevimab is a drug which can be given once only and it will prevent problems or this RSV infection in almost all the groups that they have enrolled. But then in the older age group, more than 3 months, the results were not, the confidence interval was on both sides of the 0. So that means the effect was not significant. Generally would be taken as, even if other questions say that P value is okay, the rest of things, yet we will not be able to say that in children more than 3 months, infants more than 3 months age, that this was an effective intervention. Yes, it's a very important study in the sense that RSV is a major culprit in lower respiratory tract infections in children, bronchiolitis or even pneumonias. And if we can prevent it or significantly decrease the incidence by giving only 1 shot, it is something worth it. However, the cost effectiveness or the cost benefit ratio is something which they have also probably said in their discussion that they have not worked out. And it will also depend on vary from country to country. So that is another point that we have to keep in mind. And finally, I think when it comes to applying these studies, which are being done in the Western countries, where the kind of climate, weather, the incidence of RSV and all may be somewhat different from ours, and the season also may be somewhat different from ours. That is one more point that we have to consider when we want to generalize these results to our own setting. So those are some of the initial points, and as discussion goes, we'll see. So over to you, Dhruv.
Thank you very much, sir. I think we will now request the mentor, Dr. Naveen, for his comments and inputs.
Thank you, everyone. I think very well presented study, Sumaya, very well, thoroughly. More than what I expected you to do, actually. Well done. So I think, yeah, so it's an interesting study. It's an industry-led study, actually, which kind of makes it a bit tricky to fully go with sometimes. But the study was done with a fair bit of rigor. And there are studies which have preceded this and followed this also. Again, in all industry-led for this particular molecule, actually. Now, this study very typically is done all in healthy individuals with very clear exclusion criteria. They've taken away the anybody with any comorbidity. So pretty much it's a trial of healthy infants and prevention of serious RSV infections. What was very interesting was the 3 month efficacy. I mean, efficacy only clearly shown in kids less than 3 months, which is really very hard to explain. And I think there's been some discussion in the paper, but it was not very clear what it was all about. So why this difference, and does it really make it kind of valuable to us at all is the question, really, because so 3 month, I mean, how many 3 month olds we end up giving palivizumab or this particular drug potentially? So that's one thing. So that was very unusual, the whole 3 month and not as efficacious in 3 to 6 and more than 6. Because I think what my target group would be high risk individuals who probably in all the age groups from, let's say, 0 to 12 months. And if you look at the palivizumab guidelines, I mean, whether we're going to use similar guidelines for this drug when it comes. So I think that puts it on a slightly tricky plane actually for this particular study. And the other thing is, one of the things we talked about was why didn't they go through with the full kind of time frames? And they have talked about meeting the power and early analysis. Just wondered if they could have gone through with the full analysis really rather than rush through the analysis. Again, as I said, it's an industry-led paper in a very good journal actually. So I think it's very tricky to kind of analyze those particular aspects. So I don't know why they didn't use a placebo. Potentially they could have, but they didn't. Again, it's a phase 3B, more of a pragmatic trial, so they didn't need to, I guess. So that's one thing. I'd like the study to be extended to really high risk infants and see what happens in those children who have a potential for much severe RSV infections. But having said that, if I have a family with a 6 month old child, the family are very worried about RSV in a very severe season, a lot of kids getting admitted. Do we hold off this drug? I'm not very sure. I think that's something which I think as a group, all of us need to discuss. We worked out the cost benefit ratio actually. It's very interesting. I mean, we called up the suppliers of this particular drug, which is available. I think where was this, Sumaya? I think one of the places, I think based in Mumbai or Delhi. So they do supply this particular drug. You get 5 vials of it. We worked out the cost of each of the vial versus palivizumab, roughly, and pretty much it's coming to about the same cost or slightly cheaper actually. So one dose of this particular drug in the current context seems to be equal in cost or slightly cheaper compared to a single dose of palivizumab, so which would be 5 doses. So from a convenience point of view, it's a fairly convenient way of giving it. From a cost point of view, it's not very expensive compared to palivizumab. But there are definite flaws in the study which all of us need to discuss and be aware of. Thank you.
So thank you, sir. Dr. Sumaya, you can take a look at the questions in the chat box. And if anybody else would like to offer a comment, please offer now. Otherwise, I will offer some insights from my understanding of this
Dr.
paper.
Dr. Joseph, could I just make a comment? Hello?
Hello.
Dr. Joseph, can I make a comment?
Yes, sir. Go ahead, sir.
Yeah. In this study, they had enrolled children who were either before the season or during the season. A majority were during the season.
Yeah.
So I was wondering, will that be something which will be having some effect on the results? That is, if we give it somewhat before the season. Although I know it's the antibody ready-made immunity, but and not like a vaccine which will take some days, weeks to be effective. But still, is that a point that probably we should be analyzing separately, that those who received the vaccine, sorry, the and this medication before the season started, and compare it to those who received it once the season had started, and how much into the season, say we divided the season also, let's say 2 or 3 months, and then see, was it more effective in those who received it beforehand? And no, probably they have not done that as best as I could make out of the study. Dr. Soumya, did they do that?
So basically, sir, what they have done is that the study was from August to February, sir. August 2022 to February 2023. So the RSV season corresponded to September to February, sir. So just after 1 month of starting the study. So the problem was that their primary outcome, they didn't get any much primary outcome in this out of season, sir. So majority of their primary outcome was in season, and in the table they have not calculated out of the season efficacy, sir. So that is actually not analyzed in the study.
Most of their the enrollment was during this season. I think if I remember something like 80%.
Yeah. Correct, sir. Correct, sir. Yeah. Most of the enrollment was done in the season. So they could not calculate the efficacy outside the season.
Okay, thank you.
All right, very good. So now some points for us to ponder. It will be easier for those who have read the paper. So there are a couple of things methodology-wise and a few things data-wise. The first thing, somebody has already pointed out in the chat box that there was no blinding, and the mentor also has highlighted that a placebo could have been given. That's okay, because people may not like to expose healthy children to injections which are not going to benefit them in any way. So while that to some extent would lower the methodological rating, the problem is not that. The problem is that the decision of the physicians to admit children with so-called serious illness could have been influenced by their knowledge of whether or not the child was in the nirsevimab group or in the nothing group. And this is important because if a physician intrinsically believes that nirsevimab works, which is what all of us do, then the chance that we would like to admit a child who's already received nirsevimab is much lower than admitting a child who we know has not received anything. And the proof of this is the fact that while they anticipated a 1.1% baseline prevalence of RSV in the community, their so-called control arm has a 150 percentage point greater prevalence. So 1.5% of their children had this, which means that they have been admitting children much more liberally in that side of the arm. So that is point number one. Second thing is, if you look at the data, which has not been...
Add a point, sir.
Sorry?
Can I add a point to that, sir?
No, not now. You listen and then you take all of them at the end. The second point is, if you look at the group of people who are in the very severe category, so we know that 11 infants with got the nirsevimab got admitted, and 60 infants who didn't get the nirsevimab got admitted, and there is a big difference there. But if you now look at it severity-wise, out of those 11, 5 were very severe, and out of those 60, only 19 were very severe. So the percentages are 50% on one side, and on the other side, something like 25%, or maybe about 33%. So why this big difference? This big difference is primarily because it means that people who didn't get the nirsevimab, they have been admitted much more liberally. Otherwise, you would expect the severity to be the same. And if nirsevimab was actually reducing the severity of severe illness, then we would not have expected an inflated number in the other. Third thing is, among these so-called very severe cases, look at the rate of ICU requirement. It's 40% in the nirsevimab group and only 25 or 26% in the placebo group. Again, highlighting that the criteria for admitting people in the placebo or the nothing arm was much lower than it was in the nirsevimab. And if that has happened inadvertently or advertently, we will see data which is exactly of the kind which has been presented. Now, to complicate matters, some of these physicians admitting the babies were investigators themselves, which is bound to happen when 235 sites are involved in a trial. So now those people obviously knew what is going on, so on and so forth, and things like that. So that's one of the issues with that. Then if you look at the primary outcome is got a phrase called hospitalization for RSV disease. Whereas what they actually mean is hospitalization with RSV disease. These are, only one word is different, but the meaning changes entirely. Hospitalization for RSV means RSV is proven and then they are hospitalized. Hospitalization with RSV means first you hospitalize, then you find out whether they have RSV or not. So the paper claims that they did hospitalization with RSV, but the entire data is presented as hospitalization for RSV. So this changes the interpretation significantly. One flaw which Dr. Chug has already pointed out is we have no idea how long the infants were supposed to be followed up. So because they were enrolled before and during the season, so some infants got followed up for only 1 month, some got followed up for 6 months, but almost nobody has been followed up beyond 6 months. That is evident from the graph of Kaplan-Meier, which is in the paper itself. Now, the problem with that is, if you don't follow up infants long enough, and this nirsevimab has got an early quick action because it's a monoclonal antibody, so it's possible that those nirsevimab babies will develop RSV, but much later than the babies who got nothing. So if we had a nice good follow-up for 6 to 12 months beyond the RSV season, it's possible that the statistically significant differences would probably even have disappeared altogether. The other issue is that when you look at the censoring of data once the event occurs, so as soon as a baby is RSV positive, you don't count his data any further. What we lose is we don't know if the same babies have gone and developed again RSV later on. Because nirsevimab is only a monoclonal antibody, it is not a vaccine. So once the antibody effect is gone, it makes the baby susceptible. And it's possible that the same baby goes and develops RSV 3-4 months down the line, which would not be captured because that baby's data has already been censored by virtue of the way this trial was designed. So Dr. Chug has already pointed out that there has been no statistically significant difference in the age groups 3 to 6 months and beyond 6 months. And that is bulk of the people in the study. The only thing which has swung the results is babies below the age of 3 months, which is, I think, about 20% of the babies in the study. Two things to remember, and the mentor already pointed this out in great detail. The sponsor's involvement is not just hands deep, it is hands, head, neck completely. At every step, right from designing the trial to writing the manuscript to deciding what will get published and so on and so forth, has been completely done by the sponsor of the trial, which always should make one a little careful, in which case one has to go back to the trial protocol and the registry to see whether there was anything mentioned there which has been hidden in the manuscript. It may not have happened because in this paper, the sponsor himself has been responsible for developing the protocol. Last but not the least, do not under any circumstance try to use this data for what should or should not be done in India. And the reason is very simple. The reason is this is a society wherein they are looking at babies with 1% risk of hospitalization because of RSV alone. That number is not known for India, point one. Point two, in India, the aim of protecting babies from RSV are the high-risk babies. The ones who are preterm, the ones who have congenital heart disease, the ones who have got chronic lung disease, all of which have been excluded from this trial altogether. So as the mentor correctly pointed out, for different reasons, this trial has included only healthy newborn babies as a kind of proof of concept kind of a thing, which is not your target thing. Your target is not to protect healthy newborn babies because that we are not worried about. We are more worried about bacterial infection killing them, not just RSV alone, which is the problem. So this data from this trial, even though it's very elegant and looks very impressive with all those p-values and all that, can't be used in any way for the setting that we are interested in, which is protection of babies who are at higher risk of death, either due to RSV or with an RSV infection or develop secondary bacterial infection or whatever it is, which ultimately kills those babies. Now, with those remarks, now we will send back to Dr. Sumaya. If you want to take up any of the questions in the chat box or offer any other insights or comments, this is your moment. Please go ahead.
Thank you, sir. So one point, what they have done is that statistical analysis, sample size calculation initially was done according to the 1.1%, of incidence of RSV LRTA infections. But they have done a event-driven analysis and have changed this thing. So what they have already told is that after the protocol was developed during the COVID hit times. So at that time, actually the incidence was very less, and they have got more number of incidences after the when the study was actually conducted after the COVID. That is one point, sir. Then another question in chat box is that how do you explain the low efficacy if randomization done above 3 months? So low efficacy more than 3 months, that is 3 months to 6 months, and more than 6 month group could be one reason is that actually this could be due to the lower incidence of hospitalization in this age group. Another one major reason we could poke is that this could be due to the event-driven analysis itself, in which the recent events have already occurred in less than 3 month age group, and which led to the termination of the randomization. So the events was not occurred in 3 to 6 month and more than 6 month group also. This could be also one potential reason for the same. Then another question was why efficacy against hospitalization in different countries, 89.6 to 74.2%. So basically the sample size was also different. The hit primary outcome was also different. So the efficacy was different in different countries. So did they assess the efficacy related to time gaps between injection and onset of RSV season? So we have already answered the question. In and out incidence of the season was not actually calculated due to very less occurrences in the out of season. Okay, thank you. So this is my contribution. Thank you for all faculty.
Thank you, Dr. Sumaya. Now let's see if there is anything missed in the chat box. I think not. Dr. Jagdish has pointed out that we don't have RSV in our country data on. That is not entirely correct. We have RSV data. The problem is that until the manufacturers started making products which were finding their way into India, nobody was giving any importance to the RSV data. And like happens for all infectious diseases, once a solution becomes available in the market, suddenly that disease condition becomes the #1 priority. So RSV data has been available since 2015. And it's only now that the product is coming up that now everybody is aware that, oh, it is the #1 killer of babies and so on and so forth. Nothing has changed epidemiology-wise. It is pretty much the same across the previous decade. The sample size was different in different countries. That can happen because of baseline prevalence. Study was done in NH country, whereas India falls in SH with year-round RSV. India is not SH, it is theoretically northern hemisphere only, but in some ways, especially for influenza, we behave like a mixture of both SH and NH. Now, with those remarks, I'm going to request Dr. Rawat sir for his comments and inputs, please.
Thank you, sir. Study has got, as sir you have pointed out, study has got some very serious flaws. First of all, it is a non-blinded open label study, and there is a very serious risk of bias, as we have really pointed out that the treating physician, there is a high chances that they knew that which group the child belongs to, and it is a industry driven trial. So there is all reason to believe that those treating physicians they could have been offered some money to change their preferences for admission and all. So this study has got very serious flaws, and I really don't think that the result of the study can be applied to India, seeing all these things. So until unless the study is a double-blinded study, it is not industry driven. There are very clear criteria regarding admission of children, where children are being admitted, and the treating physician is absolutely blinded regarding the group where he is admitting. Then only the results can be of some use. And as I told you, in countries where there is a year-round RSV, it will be really very difficult to plan at what stage you want to give the injection. You want to give it at discharge or for follow-up, or so there are a lot of ifs and buts. Like how do we interpret the result of the study in our practice? So I think to speak initially, this study looks impressive, but again, trying to go in detail, there are very serious flaws, and we really have to take it with pinch of salt. I agree with Dr. Matthew. We cannot apply the result of this study for India. Probably we'll have to wait for more data and more better than studies. Thank you, sir.
Thank you very much, sir. I think next I will request Dr. Jayant Joshi, sir, to offer his comments.
Am I audible?
Yes.
Audible, sir.
Yeah. Yeah. Thank you very much, Dr. Joseph, sir. I think you have brought out excellently all the pitfalls in this particular study. And I was very curious to attend today's Journal Club activity for this reason because this has been regularly done in US now. One of my relatives, or in fact, couple of my relatives have already received. And just last week, I received the pharma company's representatives telling me that this should be now the main treatment. And it is really a question, probably in the metro cities, although in NICUs now, sadly, this particular study does not really include the population which is supposed to get serious RSV disease. So one cannot make a concrete statement on that regard. But the children which I know of my relatives staying in US are receiving it, a normal children. I mean, like normal babies born, not preterm or no risk factors. But then it has been a standard of care now, and they have been giving it regularly. So whatever the industry has done, not only this paper has been successful in portraying the point, they have been successful in convincing the health authorities also, and it has become a norm now. So probably the same company in India is trying to aggressively pursue or aggressively push this thing. It is in our hands to decide, I mean, like how rationally we should take it, and we should really, either it is a hype or really it is something substantial. As Dr. Jagdish mentioned, and as you rightly mentioned, sir, that it is not that RSV is not there in our country, but because it's in a small children, so many times it is missed out, and there are serious bacterial infections which actually become more serious than the RSV population. We also have challenges in diagnosing RSV at times. So there are sort of lot of limitations in our practice to call RSV and to demarcate these children and give this particular thing. So very rightly pointed out you by sir, the fallacies, and I think what Dr. Rawat sir mentioned, I echo his feeling that we should not blindly follow this particular molecule, at least in our setting. Thank you very much.
Thank you, sir. And we have three more stalwarts who can take up in order. So we have got Dr. Kashi Bandaru, Dr. Ajay Kumar, and Dr. Sanjay Bafna. Your comments and inputs, sirs.
I think, sir, first Dr. Bafna, sir, put his comment. I invite
I
Dr.
think
Bafna, sir. I invite Dr.
I think
Bafna,
most
sir.
of the things have already been said. Yes, good evening, everyone. I think Dr. Joseph, Matthew, and Dr. Chug has already pointed out the fallacies of the study, the limitations of the study, and of course the applicability in the Indian context in healthy babies is of course out of question. But we are looking for a preventive aspect in high-risk babies. That's what I think was pointed. Otherwise, I think nothing more from my side. Thank you so much.
Okay, thank you, sir.
I think, sir, from my side also, sir, already so many things are already discussed. There are so many falsities in the study, as well as we can't recommend these things in our setup. So already, sir, discussed, sir. So nothing more than from my side, sir.
Okay, thank you, sir. And we have now Dr. Kashi.
Dr. Kasi, any comment, please?
Probably is not there.
Not there.
Yeah, it's possible. So before we close, I must, compliment Dr. Sumaya on several important things because she has read the paper meticulously. She has taken the efforts to go and read some of the statistical stuff which normally people don't. So well done on that. She has also gone, I think, into the supplementary items and files which are available with this particular paper. And she has also made great effort beyond the Journal Club to go and read up about RSV and also other trials, which have been done with this particular molecule and so on and so forth, all of which will contribute to a robust understanding for her also and has helped us also very much to be able to understand this paper better. And I'm sure all this has been possible because of the guidance offered by Dr. Naveen, her mentor. And this has made this whole presentation very nice and very useful in terms of learning. So if there are no other inputs on behalf of Dr. Indu, who is much more pleasant face than myself, on a tired audience at 10 p.m. in the night, let us close this particular session and offer her also our thanks in absentia, because she does this extremely nicely and makes it a very enjoyable session.
But sir, you have put your video off, so we can't see your present or otherwise.
Because what is
Very
happening is
deliberate.
when my video was on, 4 times I was getting kicked out from the Zoom meeting. So switching it off helps me to remain in this. Yeah. But
Thank you,
nothing
sir.
like Dr. Indu, let me tell you. All of us can be assured of that.
Thank you all.
Thank
Good
you,
night.
Thank you
everyone.
very
Good
much.
night.
Thank you.
Bye bye.
Dr.
Thank you all,
Ajay Kumar.
sir.
Thank
Sir.
you, Dr.
Bye,
Ajay Kumar.
everybody.
It was a
Thank
very
you, sir.
important article.
Yes.
And thank you. Yeah.
Thank you, sir. Thank you, sir.
Yeah. Bye.
Thank you.
Good night,
Thank you.
sir. Good night. Good night, all of you, sir. Good night,
Good
sir.
night. Good night.
Good night, sir.
Good night.